the privilege to welcome all to the CallFit Colon Cancer Screening Program, a comprehensive screening program designed to detect and prevent colorectal cancer at an early stage. This initiative aims to improve survival rates, reduce treatment costs, and address the concerning trend of late-stage diagnosis, which currently lead to poor outcomes and higher healthcare burdens. We extend our heartfelt thanks to the press and media for joining us today. I extend a warm welcome to Dr. Venkatesh Munikrishnan, Dr. Sendil Kumar Ganapathy, and Mr. Karan Puri, and I request them to come onto the stage. To formally begin today's program, I invite Mr. Karan Puri, CEO, Apollo Proton Cancer Center, whose unwavering support has been instrumental in driving this initiative to deliver the welcome address.
Dr. Senthil Ganapathy, Senior Consultant Colorectal and Robotic Surgeon. Dr. Venki Munikrishnan, Senior Consultant Colorectal and Robotic Surgeon. Clinical team, Apollo family members, medias of the press, and all my friends. A very warm welcome and a good afternoon to all of you. It's my privilege to extend a warm welcome to all of you on this important initiative that we are launching today. Colorectal cancer is an emerging health concern in India, with cases rising by 20 to 30% over the past 2 decades, particularly in urban areas and among younger adults. In response to this alarming trend, Apollo Cancer Centers is proud to launch its first comprehensive colorectal cancer screening program, the COLFIT program. This groundbreaking initiative aims to enhance early detection and improve survival rates through proactive screening and awareness. By introducing a test, which is the fecal immunochemical test, the FIT test, in India, we are improving operational efficiencies and ensuring faster, more accurate diagnostics. Additionally, the COLFIT program will educate individuals on symptoms, risk factors, and the importance of a healthy gut microbiome, emphasizing lifestyle choices. Early detection is crucial, and we all know that. We strongly encourage adults under 50, especially those with a family history, to prioritize their health, do regular screenings, including colonoscopies. By participating in this program, young adults can take control of their health significantly, reducing their risks of colorectal. At Apollo Cancer Centers, our mission is very clear: to advance early detection, provide world-class treatment, and drive awareness to combat colorectal cancer in India. Thank you for joining us today. Together, let us work towards a healthier future.
Thank you, sir. I now request Dr. Sendil Kumar Ganapathy, Senior Consultant, Colorectal and Robotic Surgeon, Apollo Proton Cancer Center, to set the context of today's program.
Good morning, everybody. Talking about COLFIT, this is an excellent an idea. This is a first of its kind colorectal screening program in a large scale for the first time in India. In a country like India, it is very difficult to formulate a government-sponsored screening program. That is what happens in the NHS in the UK and the US, where the government sponsors the screening program. But however, in a very populated country like India, that is very difficult, and it is us in the private space that we have to arrange things like this. So, to set the tone, what is screening? I think there are 4 key words in this definition of screening. One is the systematic application of a test. Who do we apply this test to? Those who are at risk and of a specific disease. And what is the purpose? To detect the disease early, and means even before the patient has started to develop any symptoms. So that is when we apply this screening test to the people at risk. So when should a disease be screened? That disease should be common. So we cannot screen rare diseases because it will not be, one, it will not be cost effective, and 2, it will not bear fruits. Second thing, an effective screening test should be available. So if we do a test, That should be a reliable test, that should be a safe test, and that should be a cost-effective test also, and a test which is not associated with too many complications. So that was the second criteria, and the third and even more important criteria is, okay, so we have applied a screening test, we have detected a disease. Are we going to make a difference by doing that? Only if the early detection of a particular disease gives a high chance of cure and gives very good outcome, then those are the diseases where we have to apply the screening test. So how does colorectal cancer fit into this picture? So does colorectal cancer satisfy these three criteria? First one, colorectal cancer is common in the Western countries, in the US, UK. It is the incidence is quite high, but however, of late in these countries, because of the application of screening programs, the incidence is reducing. But in countries like India, where there is no screening program, the incidence, even though it is much less compared to these Western countries, but it is on a rising trend. Colorectal cancer is increasing in India and most of the Asian countries. So yes, it is becoming more and more common. To detect colorectal cancer, we have simple test, because one of the first symptoms of colorectal cancer is detecting blood in the stool. Sometimes people see the blood in the stool and then they go to a doctor, get it checked. But however, sometimes we cannot see the blood in the stool because it is the microscopic blood or occult blood, that is what we call. So in order to detect this occult blood, we have very simple tests. That was what Karan was mentioning as the fecal immunochemical test. So simple tests are available, and if this is positive, a very reliable test called colonoscopy, which can detect the cancer 100%. And then in colorectal cancer, we can definitely say that early detection results in cure in most of the patients. I would just like to give you a statistic which has been given by the American Cancer Society. You can see that if it is a localized disease, both for colon and rectal cancer, the cure rates or the 5-year survival rates are more than 90%. Even if it is like stage 3, where it is a local regional disease, still we get cure rates of about 75%. So this is a fantastic outcome, and hence we have to aim for this. So what is the added bonus we get out of the colorectal cancer screening? So when the patient is detected to have blood in the stool by a fecal test, and then when they undergo a colonoscopy, and if we detect polyps, if we detect cancers, they go straight for treatment of the cancer. Whereas if we detect polyps, then we have the opportunity of removing these polyps, which gives the opportunity of preventing a future cancer. Because these polyps, if they are left alone for 5-10 years, these are the ones which turn into cancer. So we have the added bonus of preventing the disease, and this is how the incidence has reduced in Western countries where the government-sponsored screening programs are happening. So this is the global cancer statistics released by the WHO. The one on the left says about the incidence of colorectal cancer. So by doing screening, we can reduce the incidence by removing these polyps. And on the right hand side, it is the mortality which is associated with the colorectal cancers. We can definitely reduce the mortality by detecting the cancers early. Instead of stage 4, if we can detect in stage 3, or if instead of stage 3, if we can detect in stage 2, then it gives a great opportunity of reducing the mortality. So next, about the screening program which we are planning. So whom are we going to target for the process of screening? So we can't apply it to everybody in the general population. So we have to select whom we are going to screen to get the the most effectiveness. We screen people who are aged between both men and women between 45 and 75 years because they are the ones age-wise highest at risk of having a colorectal cancer. So once they reach the age of 45, we suggest to do a fecal immunotest if to detect the presence of any blood in stools. This is the age group where without any symptoms or without any added history, they can get themselves screened. And outside of this age group, who all should be screened? So anybody with a strong family history of colorectal cancer or a personal history of colorectal cancer which has not been, who has not been on adequate surveillance, and people who recently developed some change in bowel habits which got better on its own, or had some bleeding which got better on its own, so they didn't have themselves checked. If these things have happened recently, even if they are aged less than 45 years, so better they also get screened. And all these familial syndromes, people who have the history of familial polyposis syndromes, adenomatous polyposis, HNPCC, they come under a special category and they also should be screened. So the fecal immunochemical test, very simple test, non-invasive test, just need a sample of stool and it's mixed with the reagent, put inside like a dipstick test, just like something like a urine pregnancy test, and it shows either positive or negative. Very cheap as well. So that is the fecal immunohistochemical test. And colonoscopy is a procedure which is done in high-risk patients. We directly do the colonoscopy. Whereas if it is low risk and the patient is positive for FIT, we do this. It is an invasive test, but it is very safe nowadays. It can be done under sedation without any discomfort to the patient, and it can be done as a day procedure as well. And the patient also gets a blood count checked, which if there is anemia, then they also become a high risk and they will get investigated. This is a summary of whom we are going to target. Those 45 to 75 years, family history, personal history of previous colorectal cancer, personal history of polyps before, for which adequate surveillance has not been done, known family history of hereditary colorectal cancers, and history of radiation to the abdomen. So in the screening program, first once the patient comes and attends the screening program, they get registered, and then initially consultation is done by an expert, either a medical or a surgical gastroenterologist, and they stratify the risk of the patient, whether they fall into the low risk category or the high risk category. If they fall into the low risk category, blood count is done and fecal immunotest is done, and then that is on the first day. And the second day, when the patient gets the report, and if it turns out to be positive, the second day does not need to be a second consecutive day. They can come on another day also for a colonoscopy if the FIT is positive. And even in these, there can be a lot of false positive cases also. So some of them might turn out to have a cancer. Most of them may not have any cancers, but may have some other problems like piles or polyps, which can get detected, which can get treated. So in the high risk group, our recommendation will be to get a blood count checked and directly go for a colonoscopy, and as per the results, we can make a plan for that. So registration, risk stratification, doing the test, and then reporting, and then post-screening, counseling, and management. In short, these will be the program flow. So pricing, it has been competitively priced, keeping it as a service to the society, and different pricing for metro and non-metro cities. And this program is to be done. It is a pan-India program to be done across all the cancer centers of the Apollo. In Chennai, it will be 3 cancer centers: the Apollo Proton Cancer Center, the Apollo Cancer Center Tenampet, and the Apollo Cancer Center in Vanagaram. And we have specific doctors who will be doing this program. So patient eligibility, once again, it's the same thing. Don't want to repeat. And thank you very much for patiently listening. I'm sure this will be of a great success. Thank you.
Thank you, sir. Ladies and gentlemen, please join me in welcoming Dr. Venkatesh Munikrishnan, Senior Consultant, Colorectal and Robotic Surgeon, Apollo Proton Cancer Center, to speak to us about Apollo Rectal Cancer Program. He is one of the very few doctors in the country who has a sub-specialized approach to colorectal cancer treatment.
Good afternoon. Welcome to our launch of the ColFit screening program. So we've been talking colorectal at Apollo for almost a dozen years now, and it underlines our efforts to increase awareness about this problem within the community, across the country, and around the world. Can you get the slides? So why is it important? As my colleague Dr. Senthil was talking to us about the incidence, if you look at the incidence of colorectal cancer in the UK or the US, it's about 35 per 100,000. In India, it's about 4 per 100,000. So there lies in the problem why we don't have a very effective screening program, because it's not cost effective. Now, but that also gives us a conundrum. Because we don't have a screening program, every month we see patients who turn up on our outpatients with advanced disease. Now, how do we address it? We could address it in different ways. One, by creating more awareness so that patients can self-present. Now, how do we create more awareness is by talking to them about symptoms. As we know, the most common symptoms related to colorectal cancer are rectal bleeding, change in bowel habit, which could be diarrhea or constipation, weight loss, or anemia. So these are very common symptoms. And if you have that for more than 6 weeks, you should go see your doctor. Now, the problem, or the bigger problem, which we see in our communities across this country and in the subcontinent, is that rectal bleeding is such a common problem. And I'm sure some of us in this room have had those symptoms. And it's very common to ignore them because we think, ignore them because, one, we are embarrassed about to talk about these symptoms, or we ignore them because we think it's something simple like piles. Now, there lies the challenge, and that is why screening programs like this have to be started. Now, the other problem which we face is that, okay, our incidence is low, which is great, but if you look at the volume of patients, in the UK, it's 35,000 cancers, colorectal cancers in a year. In India, it's close to 70,000 because of the sheer population we have. So if our incidence is only 4 per 100,000, our morbidity and mortality, people dying from this cancer, should be low. But it's not the case because we don't have a screening program, patients present late. And so our incidences, our mortality rates are as high as 60% in this country from colorectal cancer. But if picked up early, we can cure the problem. So that is why it becomes so important, so important to have some form of screening program. So in a screening program, it could be from asymptomatic patients. Who do we screen if they are asymptomatic? Now that becomes an even bigger conundrum in Asia, because we are seeing young Asian males, particularly in the subcontinent, presenting with rectal cancer. So can we start screening at a young age? It's a difficult thing as a program to start, but I think as of now, we would say if you're asymptomatic but 50 years of age, we should get a screening colonoscopy or get into a ColFit program like this, where we can get your fit test done, and if it's positive or negative, you can get into the pathway. But if you're symptomatic, then you should definitely come and get this, be part of the ColFit program, and then we can assess you and find out what's wrong with you. So those are my thoughts on why we need to have a program urgently, why we need to start it across the country and create more awareness. Now, Senthil and Karan have already spoken about what the program is, and if we get a problem diagnosed, what do we do? Hopefully, it will be at an early stage, we can cure it. It's advanced, then we may have to give it palliative treatment. So, to treat these patients, we developed a very specific program, the Apollo colorectal program, which has been in place for 12 years now, but more so in the last 12 to 14 months, we developed the Apollo rectal cancer program, which is we call the ARC program. Now, if you look at the history of how our programs evolved, it's taken 12 years for us to get to this stage to be very, very subspecialized in this area. And the Apollo robotic colorectal surgery program reflects onto what we've developed in this space. Now, in our program itself started in 2015, where we got in subspecialization. Basically, if you have these symptoms, majority of the hospitals, you have to go in and you will have to try to find which specialist to go to. Here in our center, what we've done is basically subspecialized, and we basically have a single door policy. Patients who have colorectal symptoms or been diagnosed with can open that door, and you'll have all the specialists sat in that area who can take you through that journey together without you have to go to different places. And that makes the patient's journey quicker, safer, faster, with the better outcomes. And that's why subspecialization is so important. So what we've been doing, we've had huge experience in this space. We use robotic surgery to clear these cancers. Close to 800 cases have been done robotically. Our program is steadily growing. It's got some of the best outcomes in the world. Our wound infection rates, when we deal with these cancers, are some of the best outcomes in the world. Our cost is the cheapest. We've created the most cost-efficient robotic colorectal cancer surgery program. When patients are diagnosed, we can cure them with this specific program. So we've basically used robotics as the primary mode of treatment, and the cost efficiency has made a huge difference. So we are the only quaternary care center for rectal cancer management. Here we use advanced technologies, right from screening, assessment using advanced MRI, CT, PET CT, then chemoradiotherapy using standard radiotherapy and proton therapy, and robotic surgery to completely, it's a 360, treatment capability right in one place. And I think that's what differentiates us from all the other cancer centers, around the world. So, having said that, we've got a lot of training programs which address or teach these techniques to other teams around the world, and in that we have specific teaching and training for how to stage the disease, multidisciplinary decision making, theater setup, ERAS, robotic surgery, and follow-up. And so we not only are offering these treatments here in Chennai, but we also want teams across the world who are treating colorectal cancer, it may be in Apollo or any other hospital, to come and learn from us how we're doing it. We're also working on a new program where we should be able to use our expertise in robotic surgery, use telesurgery, and to offer our expertise in other hospitals or within the Apollo ecosystem, so that this expertise in colorectal cancer care can be taken. Basically, surgeons sitting in Chennai can operate in, for example, in our Delhi hospital or our Hyderabad hospital when they need a dedicated robotic colorectal surgeon, because we are the highest experience center in robotic surgery across the country. So with that, I would like to close, what I wanted to say about the ARC program, and we're happy to take questions.
Thank you, sir, for that insightful discussion.